Hi, welcome to the part 2 of the lecture. We will start with the non-neoplastic lung lesions of vascular origin. We start with pulmonary embolism. There are multiple predisposing factors. Probably the most important predisposing factor is actually immobilization and hip fracture. When the patient is immobilized, the patient is prone to having thrombus, and this will tend to embolize. And patients with hip fracture, the treatment is immobilization. So these two are related. And the next predisposing factor is patients with underlying diseases such as cancer, cardiac disease, and so on. Patients with hypercoagulable states such as factor V Leiden and antiphospholipid syndrome have a tendency to for thrombosis, and that will lead to embolism. Patients with indwelling central venous lines will tend to have a thrombosis on the central venous lines, and that will tend to embolize as well. The effects of pulmonary embolism can be divided into two. First is respiratory compromise, and second is hemodynamic compromise. Respiratory compromise happens when our body is trying to ventilate the non-perfused segment of the lung, and that will exert a lot of effort of the lung to ventilate that particular segment. And for hemodynamic compromise, our body will try to pump the blood into the place where it is non-perfused, so that will exert a lot of effort for our body to pump to that particular segment as well. This is how pulmonary embolism manifests in the lung. The first is saddle embolus. This is when the large embolus is lodged in the main pulmonary artery or main branches, and this is a common cause of sudden death. And there is a acute cor pulmonale as well. This is right-sided heart failure due to pulmonary embolism. And if there is a smaller pulmonary emboli, it will lodge into smaller vessels and will cause hemorrhage and infarction. So this picture doesn't show saddle embolus, but it shows smaller emboli lodged in the smaller pulmonary vessels, which is highlighted in these circles. And this is during autopsy examination. So in autopsy examination of the lung, examination of the pulmonary vessels is required because we want to rule out pulmonary embolism as a cause of death. Next is pulmonary hypertension. It is associated with chronic obstructive or interstitial lung disease, previous congenital or acquired heart disease, known case of these heart diseases, recurrent thromboemboli, connective tissue diseases such as systemic lupus erythematosus, obstructive sleep apnea, and it can be idiopathic as well. The morphology of pulmonary hypertension, if you see the muscular and elastic arteries, there will be medial hypertrophy, and you can also see atheroma of the pulmonary artery as well. Diffuse pulmonary hemorrhage is composed of generally Goodpasture syndrome, Wegener granulomatosis, idiopathic pulmonary hemosiderosis. This may be a bit advanced for basic pathology of the lung, but you can look at it further reading, especially for Goodpasture syndrome and Wegener's granulomatosis. For interstitial lung disease, it can be divided into fibrosis, granulomatous, eosinophilic, smoking-related, and others. But for basic pathology, probably the most important part that you have to know is sarcoidosis. Sarcoidosis is a type of idiopathic granulomatous condition affecting the lung, and also pneumoconiosis, which is an occupational disorder involving the lung. So you probably have to read up on those if you're interested. So next we'll go to neoplastic lesions of the lung. The etiology of the lung carcinoma, the most common etiology is cigarette smoking. Next is asbestos inhalation. So this is particularly in patients who have worked in shipyards and patients who work in old buildings, so they use asbestos and they tend to inhale the asbestos. Next is heavy metals such as nickel and cadmium, and finally genetic predisposition can predispose to lung carcinoma. Lung carcinoma basically can be divided into four. First is squamous cell carcinoma, second is adenocarcinoma, third is small cell carcinoma, and last but not least is large cell undifferentiated carcinoma. So small cell carcinoma and adenocarcinomas, which one is more common? It used to be it used to be squamous cell carcinoma, but now adenocarcinoma is rising in incidence. So in the US, adenocarcinoma is already the most common type of lung carcinoma, which is 40% of all lung carcinomas, while squamous cell carcinoma is the second most common lung cancer in the United States, which is about 25 to 30% of lung carcinomas, and my source is the American Cancer Society website. I think the trend is now nearly similar in Malaysia as well. We tend to see more adenocarcinomas now. But because squamous cell carcinoma used to be the most common lung carcinoma, I will proceed with squamous cell carcinoma first. This is a picture of squamous cell carcinoma. There are nests of malignant squamous epithelium with keratinized cells and presence of a keratin pearl here on the left hand side here. With the eye of faith, you may see intercellular bridges, which is characteristic of squamous cells. So that's how you can identify squamous cells. And between here, there are inflammatory cells in between the malignant squamous cell nests. So for squamous cell carcinoma, in the lung, it usually arises near the hilum, and it is associated with keratin formation and keratinization of the cells with squamous pearls and intercellular bridges, as you can see in the picture here. Immunohistochemistry, you will see it is positive for CK5, 6, and P63, and it's associated with hypercalcemia, which is a paraneoplastic syndrome in which the tumor produces parathyroid hormone-related protein, or PTHrP. Next, this is a picture of adenocarcinoma, and if you can see on your right hand side, that's the normal alveoli that you see here, and this is the malignant glands, which are separated by the desmoplastic stroma. And unlike squamous cell carcinoma, adenocarcinoma arises at the peripheries of the lung, and it is associated with old areas of scar tissue. For example, patients with old tuberculosis scar, they have a tendency for adenocarcinoma to occur there. Glands, papillae and mucin can form as the histology, and this is the microscopic picture of the lung showing formation of papillary projections or papillae within the lung, and this is adenocarcinoma as well. Immunohistochemically, it will be positive for TTF1 and napsin A. If you read the older textbooks, you will have encountered the term bronchoalveolar carcinoma, which is an adenocarcinoma, but the malignant cells only involve the alveolar wall lining. However, the term is now rendered obsolete. So in the recent update for lung pathology, bronchoalveolar cell carcinoma is now replaced with the term adenocarcinoma in situ, and this is a lesion which is less than or equal to 3 millimeters. I apologize for the typo here. And There is another new term as well, formerly known as non-mucinous bronchoalveolar pattern of invasive adenocarcinoma, which is now known as lipidic predominant adenocarcinoma. So this is when the features are similar to adenocarcinoma in situ, but there is an invasion of malignant cells of more than 5 millimeters. There are other variants of adenocarcinoma as well. Okay. For squamous cell carcinoma and adenocarcinoma, there are different pathogenesis. So for squamous cell carcinoma, the normal bronchial or bronchial lining will be exhibit hyperplasia and squamous metaplasia if it is exposed to injury or insult. And if it is not removed, then the injury is not removed, then dysplasia will occur, and dysplasia can eventually evolve into carcinoma in situ when the dysplasia involves the full thickness of the epithelium, and eventually the carcinoma in situ will lead to invasive carcinoma. Meanwhile, for adenocarcinoma, this is the normal alveoli and this is normal bronchiole, and there is a term called atypical adenomatous hyperplasia, and this is a precursor for adenocarcinoma, and that will lead to adenocarcinoma with lipidic pattern, or eventually can evolve into invasive carcinoma of acinar pattern, and this is a classical adenocarcinoma. For small cell carcinoma, it is composed of neuroendocrine cells, and it is composed of these tightly packed small blue cells with nuclear molding, so it is molded to one another, and it has a fine chromatin, or in some textbooks will say salt and pepper pattern, and there is very little cytoplasm. And you can see some mitotic figures here. Okay, small cell carcinoma is a type of neuroendocrine carcinoma, and it is related to paraneoplastic syndrome, which involves hormone secretions such as ADH and ACTH. And immunohistochemically, it will be positive for synaptophysin and chromogranin, and also nonspecific enolase or NSE. Large cell undifferentiated carcinoma is a diagnostic term when we are unable to classify lung carcinoma as squamous, small cell, or adenocarcinoma, and they don't have the typical morphological feature, and they do not have the typical immunohistochemical features. So morphologically is composed of all these malignant large cells, which is negative for all the immunohistochemistry that I mentioned before. Carcinoid tumor is a type of neuroendocrine tumor, but it's not a carcinoma as yet. So it may arise centrally or peripherally, and it's composed of small rounded uniform nuclei with moderate cytoplasm. It has a fine chromatin, salt and pepper chromatin, like neuroendocrine carcinoma or small cell carcinoma, but it's not malignant. Okay, so please do not forget that metastasis can happen in the lung, so it's usually in radiographs, it can look like a cannonball lesion, and it can also be a solitary nodule, endobronchial nodule, pleural nodule, or present as pneumonic consolidation. So just some updates on lung pathology. There's EGFR, ALK, and KRAS mutation. So there are different treatments for different types of mutation. Mesothelioma occurs almost exclusively in those exposed to asbestos, and it grossly encases the lung in a hard white shell such as this, and this is the lung actually. So histologically exhibit glandular epithelial component and spindle-celled stromal component. And last but not least, this is not exactly lung pathology, but you have to know mediastinal tumors. So that's it for lung pathology. Thank you for watching and listening.